Okay, so today we're diving into a condition that you hear about in pregnancy called placenta previa. It might sound a little intimidating, but the truth is, with the right information and great medical care, it's a very manageable situation. All right, let's get into it.
So to really wrap our heads around placenta previa, we have to start with a pretty fundamental question. What happens when the placenta, the literal lifeline for a growing baby, ends up in a spot that could block the baby's only way out?
Here's a quick look at our game plan. We're going to start with the absolute basics, then we'll look at who might be at higher risk. After that, we'll see how it's diagnosed and monitored, how the pregnancy is managed, and finally, we'll cover the potential complications and the general outlook.
First up, let's build the foundation. What exactly is placenta previa?
You know, in the simplest terms, it's all about location, location, location. The placenta, which is the baby's entire life support system in there, attaches way down low in the uterus. And you can probably guess, if it's covering the cervix, which is basically the exit door, that can cause some pretty big problems for a vaginal delivery.
So, to understand what's different, let's first look at what's typical. In most pregnancies, you get this ideal setup. See how the placenta is attached way up high on the uterine wall? It's completely out of the way, leaving a wide open path for the baby. This is exactly what we want to see.
Okay, now let's see what happens when that location shifts a little bit. This is what's called a low-lying placenta. As you can see, it's implanted lower down, and the edge of it is getting pretty close to the cervix, less than 20 millimeters away. It's not totally blocking the exit yet, but it's definitely in the neighborhood.
And this image shows the whole shebang. This is complete placenta previa. The placenta is sitting right on top of the cervix, totally blocking the birth canal. When you see it like this, it's crystal clear why a vaginal delivery just isn't a safe option.
But here's a really important and honestly pretty reassuring number. If a low-lying placenta is caught early on, say during that mid-pregnancy scan, about 90% of the time it actually fixes itself. As the uterus grows up and out, it kind of pulls the placenta along with it, moving it away from the cervix.
So that brings us to the next big question. Who is more likely to develop placenta previa, and are there clinical reasons for it? Let's look at the who and why.
Well, the science really points to a strong connection with any kind of scarring on the uterus. That's why the single biggest risk factor is having had a C-section before. Any surgery that leaves a scar can create a spot where the placenta is more likely to implant down low. Other things like being over 35, using IVF, or even smoking can also play a part, probably because they affect the uterine lining or blood flow, which influences where that placenta decides to set up shop.
And this slide right here is so important to understand. It shows how the risk for a related and much more serious condition called placenta accreta just skyrockets with each C-section if you also have placenta previa. We'll get more into accreta in a bit, but just look at that jump. From 3% after one C-section to a mind-blowing 40% after 3. It just hammers home that powerful link between uterine surgeries and these kinds of placental issues.
Okay, now that we've covered the what and the why, let's get into the how. How do doctors actually diagnose this, and what do they do to monitor it throughout the rest of the pregnancy? You know, the classic textbook sign that often leads to a diagnosis is sudden bleeding. And it's very specific. It's painless, and it's bright red blood, usually happening in the second or third trimester. Sometimes it can be triggered by something, but a lot of the time, it just happens out of the blue.
Thankfully, we have a super safe and really reliable tool to get the final answer. The definitive diagnosis comes from an ultrasound. In fact, a lot of the time, a low-lying placenta gets flagged for the first time during that routine anatomy scan that happens around 20 weeks.
So doctors usually use two different kinds of ultrasound. First, they'll do a transabdominal scan. That's the one you're probably used to, right on top of the belly, to get an initial look. But to get a super precise measurement of exactly how close that placenta is to the cervix, a transvaginal ultrasound is the gold standard. And it's really important to know that this is considered perfectly safe to do, even if placenta previa is suspected. All right, a diagnosis has been made. So what happens next? Let's walk through the management plan. It's all about keeping mom and baby safe right up until delivery day. The plan is actually very clear and straightforward. Number 1 is pelvic rest. That means avoiding anything that could disturb the placenta. Number 2, any bleeding at all, even a tiny bit, needs to be reported to a doctor right away. Number 3, there'll be regular ultrasounds to keep a close eye on where that placenta is. And finally, if the previa doesn't move up and out of the way, a planned C-section is going to be the way to go.
And the timing of that C-section is absolutely key. The whole idea is to deliver the baby before labor can start on its own. Why? Because the contractions and the stretching of the cervix during labor could cause the placenta to tear away, leading to really severe bleeding. So scheduling that delivery, usually between 36 and 37 weeks, is the safest bet. Now, we have to talk about the potential complications, because they really highlight why all this careful management is so incredibly important, and will also properly introduce that related condition we touched on earlier. The number one risk, hands down, is hemorrhage, or severe bleeding. The lower part of the uterus just doesn't contract as powerfully as the top part after the baby is born. That makes it a lot harder to stop the bleeding from the spot where the placenta was attached. Preventing this is the main goal of all the management protocols.
And this brings us back to the placenta accreta spectrum, or PAS. This is a serious situation where the placenta doesn't just attach to the uterine wall, it actually grows into it. And as we saw in that bar chart earlier, the risk for this goes way, way up for someone who has both placenta previa and a scar from a prior C-section. It's a dangerous combination.
And it's called a spectrum because it's not just one thing, it's a range of invasion. It starts with accreta, where it's just stuck on too tightly. It gets more serious with increta, where it's grown into the muscle. And in the most severe cases, you have percreta, where the placenta has grown all the way through the uterine wall and can even attach to other organs, like the bladder.
Because the risk of massive bleeding is so high, managing a suspected case of PAS is a huge team effort. It requires a whole crew of experts, obstetricians, anesthesiologists, radiologists, surgeons, all working together in a specialized hospital to plan for every possible scenario and give mom and baby the safest possible outcome.
And all of this brings us to one final, really big thought. It's clear that as C-section rates keep climbing all over the world, complex issues like placenta previa and the placenta accreta spectrum are going to become more and more common. So it leaves us with a critical question for the future of medicine. How are we going to continue to innovate and evolve to manage these challenges safely and effectively?